Today's session is going to focus on disaster planning for CMC, preparing for the unexpected. Dr. Turchi, Renee Turchi, is going to be presenting the lecture. Renee is a chair of pediatrics and pediatrician and chief of general pediatrics at St. Christopher's Hospital for Children. She is medical director of the Center for Children and Youth with Special Healthcare Needs at St. Christopher's Hospital for Children in Philadelphia, a primary care practice dedicated to children with medical complexity, including an FESD interdisciplinary team, a NICU primary care follow-up program, and grant-funded projects focused on SHIN and disaster preparedness. Her patients and families are her best teachers and biggest inspiration for her work. Dr. Turchi, I'm going to turn it over to you.
Thank you so much, Amy, and thanks for inviting me to be here today. I have no disclosures. Thank you. You can go to the next slide. And here are my objectives for today's talk. I'm really excited to talk with you. Really want to first start with discuss the unique issues that are facing children with medical complexity and their families during a disaster. And then during that time, talk about the opportunities and challenges that we have with care integration, things like in-home services, community partnerships for this population and their families during a disaster. And all along, kind of woven through the reflections that I have, and hopefully our discussion will be the importance of patient and family-centered care and disaster planning for children with medical complexity. The next slide, please. So just really briefly, the background, we all know that, children and youth with special healthcare needs comprise 19% of all children. Children with medical complexity are a subset of that group, but really overall, those children have more chronic severe health conditions. And when we think about some of those challenges, they include things like mobility challenges, technology needs, whether that be with gastrostomy, tube feeding, or respiratory issues like tracheostomies or oxygen. There's also communication challenges. So whether that is, a child that might have autism or visual or hearing challenges, and then overall service needs. Many children need in-home services, therapies. Many of our children and youth with special health needs and medical complexity have functional limitations and activities of daily living. They have intellectual and developmental disabilities in some cases. And, just considering that their healthcare utilization overall is, increased compared to other typically developing children. So given that, these special needs, this complexity, the dependence on technology, the service needs really puts this population at a real risk during emergencies and disasters. And when we think about, overall, just the disruption to families and, many of us even living through the current pandemic, thinking about disasters that are disrupting things like utilities, shelter in place plans, home displacement. Well, that's challenging for all children, given what we just discussed, it can be particularly challenging for this population. Next slide, please. So when we think about disasters and, the International Federation of Red Cross describes that, disasters, and it's really been interesting for me to think about this and learn from so many folks. And this is sort of an evidence-informed kind of classification that they use. So we think about the geophysical disasters, things like earthquakes, landslides, and tsunamis. There's certainly, climate-related disasters that we've seen in the United States, droughts and wildfires. There's floods, hydrological disasters that we've seen, storms and severe weather. There's a big storm coming close to those of us that are on the East Coast right now. Meteorological disasters, so cyclones and windstorms. Certainly many of us are living through things like right now, the biological disasters, pandemics, epidemics, and plagues. And I also added this one, I think disasters for many families, while, we think about those that are non-man-made, many times, families experience personal disasters where there's a loss of a caregiver, death of a caregiver, or even some impairment of caregivers. I think many of us in practice have experienced where, you might have a child with medical complexity who is dependent on an elderly grandparent who suddenly is hospitalized or has some decrease in their ability to care for that youth or child. And those are all things that affect our patients and families that we serve. Next slide, please. And so thinking about all of that can happen, and sort of taking a more, okay, I don't mean to be Debbie Downer with listing all the disasters, but let's say, what do we do during all of those possible scenarios that we might encounter regardless of where we live or serving families? So when we think about the literature and the evidence and what's been described, communication considerations during disasters are something to really think about. In one study, there were very few families that reported having an emergency communication plan in place, and actually expressed in this particular study that they wanted education related to preparing for disasters. And there's also a lot discussed around how do we communicate and connect with families in disaster planning. And like anything else, that is going to be very personal based on that family's preference, geographical considerations, sociodemographic considerations. But that is something that's really important for us as parents, as clinicians, as agencies. One thing recently I've been working on with some of my own colleagues is, thinking about self-efficacy. And we know that, a family or even an individual's sense of self-efficacy is a very important consideration. So self-efficacy is, that sense, my own internal sense of my ability to respond or to react to a particular situation. In this case, we're talking about emergency or disaster preparedness. So if I am a caregiver of a child with medical complexity, how do I feel? What is my sense of my ability to do what my child needs, to activate a shelter in place plan or to care for that child during this very critical moment? So it's important to have a sense of that for our families and talk to them about it, and not just assume. And I think one of the things that is going to be a common theme in my reflective comments this morning is the critical importance of engaging families and youth in preparing a plan. It's like anything else where we can have, this very, elaborate plan. If we're not engaged, it doesn't matter that we hand a family, an evacuation plan. If it is, they can't get a child down a staircase in the face of a disaster. So they need to be at the heart of that. And we need to work with families on how we can help them put together things like disaster supply kits. Think about things like a meeting place, so that is, again, like many things in life, we need to be proactive and think about and have a family talk through, hey, is it, a tree across the street? Is it the neighborhood, street a block over? But that needs to be something that we can't impose on a family. We need to help them think about it, work with them to do it. And one of the things that is really important, there's a great scoping review by Tom Hipper that really looked at this issue and really talked about how families absolutely do have opinions about the content, the sources of information, the channels of education that they would like on disasters, and how they want to be engaged with healthcare and clinicians. And so there's some really good evidence around that really supports this notion that we should be talking to our families in this discussion. Next slide. So care integration during a disaster is important to consider many pieces. We want to think about, as that is, I think, really kind of the epicenter of what we're talking about, we want to have families have the development of a written preparedness plan. In this presentation, we have a number of resources at the end of the slides and in this particular slide where you can, access these samples of these to do if you need them. And also think about shelter in place plans. How is a family who might not be able to leave, what will they do to shelter in place? And again, I think a common thing for me is that proactive versus reactive. Having families prepared before it actually happens, so they're not feeling like they're flying a plane, and learning how to do it at that time. I think it's important for us to continue to think about, what is that optimal communication that I alluded to earlier, depending on, your clinical practice or what a family's, preferred method of communication is. I mean, think for most of the world these days, many folks don't have landlines anymore. If they do, it's a 911 landline. So, does a family use texting? Or is, in many cases, sometimes families don't keep the same cell phones. What is the best way? Is it patient portals? Do you have an electronic health record that can blast things out? But families need to know that that's how you're going to communicate, that your practice or that you personally are going to send an email communication. And that might include changing a workflow where you're actually garnering emails or alternative texting numbers, things like that. Or maybe it's social media. Also, sometimes thinking about, is there a grandparent? Is there a friend or relative that might have, that might be a constant, that might be someone outside of the disaster zone, and sort of think about a grandparent or a caregiver that might be in a different, in a different area. Also, I think the use of telehealth. I think this is something that, we've talked about and the American Academy of Pediatrics is looking at, and it's a total topic onto itself, but I think it's relevant here for disasters. I think COVID and others have really, some of these situations have helped us reflect on, particularly for this population, what services need to be in person versus need to be video visits. I really believe that, this sort of jettisoning us ahead in telehealth has helped us think about, even post-COVID, whenever that is, how many kids with medical complexity really need to come in multiple times a year? It might be that we're looking at, in our clinical practices, having families come in once a year and having a lot of telehealth punctuate those visits. And so I think the other thing that I wanted to highlight is the value of telehealth. Even though it might have, come to being in the inception might have been during a disaster, there is some real value to seeing a child or a youth in their own environment. We've used that a lot of my own practice, where you're actually with the caregiver, a home care nurse, you're actually able to see the equipment in the home, see how things are set up, see any challenges that a family might have. Families might not be able to bring medications into the office if they require refrigeration, but now they're able to take a device over to the refrigerator. There's a lot of things about being in the home that can help you help families best if it's something that they're comfortable with. Next slide, please. So the other thing is, really thinking about considerations for in-home services. And by that, we mean, home care nursing and any therapeutic services. I think COVID and sort of the rapid, kind of look at what these in-home services, really required. And in many cases, some folks were not able to access those services. And in some cases, families didn't want those services in their home. I think things like access and proper use of PPE, we can't order PPE through medical equipment providers to provide for families. So, we've seen this a great deal in my practice with a number of children with in-home nursing, when, especially early on in the first wave of the pandemic, when PPE was even harder to get, families didn't have adequate, medically CDC sanctioned PPE, but yet, and some of the nursing agencies didn't as well. And also teaching families. I mean, all of us in the healthcare sector have gotten a lot of teaching on, I know we expect the masks in our hospital. I had plenty of families who didn't know that cloth masks that they could just purchase or get from Joann Fabrics weren't okay in certain scenarios. So when we think about some of the assumptions we make in the healthcare system that we've gotten training on, families don't necessarily have access to that, which is why our partners in things like Family Voices and other places to be a conduit of this information is critical. I also think potential exposures to viruses. I had some own cases in my own office where families were fairly convinced that their children contracted COVID from in-home services. And, that is a pretty scary and frightening thing for many families. And also thinking about on the agency side, from their perspective, they have lots of nurses or caregivers that are unable to come out, scared to go into homes of families. So there's shortages. And then often we worry about, just adequate training of nurses. So am I now in an agency where I'm deploying a nurse into a home with a child with a ventilator where that nurse might not have the appropriate training to care for that child and their technological or medical needs? I also think that, we've also seen this in the pandemic, that a lot of the nursing agencies had contracted staff. And so we'd get these massive boluses of orders that come through. And so our ability to sign off on orders and have communication was really a consideration in the practice. And so I think for me, when I reflect on this and when I've talked with some of my colleagues and some of my partners, for us, one of the big things and a consideration and a take home from this discussion of in-home services is the critical need for training effective caregivers in this environment. When I think about this, I think about the hospital scenario. We would never have a nurse work 24-hour shifts multiple days in a row. But yet, however, somehow we have families in their homes, taking care of their children with, as the sole caregivers. And that's often not just their only responsibility. And I think what the pandemic really kind of highlighted is that in some cases, it really does need to be the family's choice. We had plenty of families that were exhausted, but they still did not want to have someone in their home during the peak of the pandemic. So I think working with families and helping them think through like, hey, maybe it's worth having, a family member, a friend, understand and be trained on some of the care, just so that a family member can feel like they can take a break. It's also, it's the pandemic, but also, as I alluded to earlier at the beginning of my talk, even if a caregiver becomes ill or unexpectedly gets admitted to the hospital, or has to leave for a funeral, just having people there so that someone doesn't feel like they're abandoning their child and have no other choices is critical. Next slide. I think one of the things, and I think this is a line that I think about a lot. This is God rest his soul, my dad, was something that he used to say, and I think about this a lot in clinical practice. So my dad, when he was teaching me to drive, used to say that it was so important, for him for us to drive together when it was raining. And he would say, I'm in the car with you. I don't want you to be finding yourself driving in the car in the middle of a rainstorm, and that's the first time you experience the rain. And I didn't really think I understood that till later in my life, like many things. And I think that, to me, it's very applicable to this situation, that we want to have families, not find themselves in the face of a pandemic with no backup trained caregivers, no extra supplies, not understanding, or even thinking about, what could possibly happen, and not being able to feed their child because they don't have power or the adequate supplies to use a gastrostomy tube. So let's try to think about that and think about, teaching people and being conscious of driving in the rain with someone when you're learning. Next slide. So that support system, in thinking about that, I think about, power is one of those ones that we often think about a lot. And so preparing for that, supplies when power is lost. So I think about that on, things like batteries and flashlights. Also, we've been recently with the pandemic getting car chargers for ventilators and having that just be ordered. Thinking about things like syringes for children that are dependent on gastrostomy tubes, so that you're ordering that out of the gate. And that not only does the family have the supply, it doesn't really help for it to be sitting there, but that we actually teach families about how to use those, and that those are standing orders, and that those orders are also reflected on those care plans. And because training on that equipment, it's not intuitive. If you've ever used a feeding pump, or converted some of the respiratory equipment we use to the charger in your car charger. Some of our families don't have cars, so thinking about some of those things. Also, right now, I was just talking about this with someone earlier this morning. For many of the Medicaid plans, there has been, I think, with the pandemic, some relaxed requirements on additional supplies for equipment or medications. But really having that adequate supply, that 7 to 14 days, is really key to having, a family, especially if they're not quite at that 30 days and a disaster hits. The disaster doesn't, take into account the 30-day mark. I also, I mentioned this already, having care plans that really outline those specifications, have those medications, have the syringes, have all of those disaster supplies on there, especially if a family find themselves displaced and not connected to their medical home or primary care clinician. Also having alarm systems for children with communication challenges. So there are things like bed shaker alarms for children who might have visual or hearing impairment, as well as lighted alarms that many of us can get and can get covered by insurance. So be thinking a little bit outside the box. Next slide. So thinking about challenges that we faced during COVID-19, for many of our children that are, finding themselves in the pandemic, not being in school has been challenging for all children. We all know this, and we've been, there have been countless, appropriate webinars kind of talking about the impact on children that the pandemic has had. And I think it really does, we really need to have a moment of pause for children with medical complexity, because for them, being in school can sometimes have even more significant implications, because many of our children receive services in school. So this might mean that they're not getting their feeding therapy, their physical therapy. And also for them, as many of my parents have and families have said, they're sitting at home, being on virtual school. If you're a child with cerebral palsy and sitting in your activity chair for 8 hours and at one computer, some of their intellectual, challenges, and we're putting this all on parents. Also, if I had a nickel for every parent that has told me how challenging some of the therapies can be and how stressful it is, that they're on a video and someone is saying to them, move their knee to this angle and stretch their leg, and they're fearful that they're going to harm their child, aside from, just the whole stress of being at home and having to switch from being the teacher to the therapist to the mom cooking dinner for the other children. I mean, all of that is a lot for anyone. We also have to think about the increased social isolation that is occurring for many of our youth and children. For many of our kids, just getting on that bus every day and those routines are things that are instrumental to that family functioning and to that child. And so every day, kind of not seeing their friends or seeing their favorite teacher or their therapist can be really disruptive and very overwhelming. The other thing to think about is this concept. I don't know how many of you are familiar with this concept of potting that one of my neighbors taught me about. And what potting involves is it's when one or more whole households like get together and they bring their children together and they can like share resources and have the children, it provides some, if they're kind of in their bubble, their COVID bubble, it allows some social interaction. It allows, some parents have used that as a way to like work share and things like that. And it's a way that some parents have chosen to survive in the pandemic, as well as sitters. And I think for children with medical complexity, that potting is not necessarily an option, right? Because if you're gonna, pod with your neighbors, does that neighbor know how to connect your child to the feeding tube? Are they going to be patient with a child and understand what it might need to redirect them to the computer, or what some of their physical challenges are there? So thinking about some of those things that many of us take for granted, I think are so totally are really exacerbated for our patients. And I know the other piece that I really wanted to mention in this is the testing. We recently opened a drive-through test site at our hospital. And for many of our kids that have had to get testing, even outside of that, for surgical procedures that have just become sort of the standard of care, even if they're not concerned about COVID itself, for many of our youth, and children with sensory and maybe some cognitive challenges, getting tested can really be challenging for families. I mean, I've had parents talk to me about how hard and how traumatic it is to be in the car and hold their child down who, and they weren't prepared for what it was like. They didn't know that the test was going to be, a deep nose, a nose swab, and all of those things. So I think we need to be thinking about how to best prepare and communicate with families in this regard. Next slide, please. I think, for me, all the things that I've said so far, where I come back to is that this partnering with families is paramount. It can't be overstated. And, this idea that I feel like I hear this every time I'm in my patient care sessions, where a parent or a caregiver is feeling like, who am I going to be in this next hour? I've had parents tell me where they just like sometimes just need to take a breath. They have something on the refrigerator and they're like, have to gear up for the fact that, okay, now I'm going to be like OT, and they have separate bowls because they don't want their child to associate, the OT bowl with the dinner bowl. They want to make sure that they eat dinner. And to think about, it's just humbling to me on a daily basis when I talk with my families about just what some of this is like for them. And I think also, we can't have this discussion without thinking about the social determinants, thinking about, the loss of jobs, or even families having to choose to take off from work because they are the teacher or the caregiver. They can't pod, they can't share. And now, poverty that ensues, or maybe it's poverty that exists. And now the spotlight on that is 25-fold. Also transportation, where I practice in Northern Philadelphia, many of our patients rely on the bus. Many of our patients that have special needs rely on like a Medicaid supported plan, but many of our families don't want to be on some of these things and they feel very uncomfortable. So thinking about transportation challenges during a pandemic, thinking about those dynamics, and thinking about, the mental health and behavioral supports. I've had plenty of families tell me that, at the end of the day, as a caregiver, they're so focused on their children that even if they had their own mental health services in place, they just don't have the time to do the Zoom for themselves, even if that service is available. It's like one more thing. So I just want to put that out there to say that we need to partner and really listen and not just dole out all of these different things or added to things on a care plan. Next slide, please. And so I think that, when we think about the disaster planning and really just trying to bring it back home here and sort of think about when we're actually planning with families and what are some concrete things that we can do. And I think even again, post-COVID, during COVID, I know for me personally, this has really changed the conversations I'm having, what we're including in, we're rolling out Epic in the next 2 months and has really helped me think a lot about what we want to include in those, visit summaries that we give to families. So I think it's not just in the clinician's office. I think what we've talked a lot about with our home nursing agencies, with schools, even though a lot of our patients are virtual, is planning across all settings that a child interfaces with, so that, if it's a school nurse that's helping, a child with their feeds, asking and having on that care plan, all caregivers are trained with the syringe. Thinking about disaster planning for home care nurses, as these are folks that are often in a child's life. So thinking about that and transcending it across all the settings. Also thinking about that disaster supply kit. So while we, do checklists with our care coordinators and go through what a family has, we call them go bags. We've also worked a little bit on lists of those, and have really trying to develop some protocols with some CDC work that I'm involved in, where we, not that I think that our staff happy to share it. I think it's iterative. We keep getting feedback from families of things that we need to add. A lot of our families have found the go bag list just great. I had a mom who recently just wanted to get out of Philadelphia, and she went like 3 counties over to be with her mom because she was scared about COVID. And she was like, I used the go bag because I was so flustered to get out of Dodge. Like, the go bag just helped me focus on what I needed to take for her child's respiratory equipment needs. So sometimes it's kind of helpful. It's like that shopping list, right? When you're in the grocery store, you forget what you need. You have that on there for families, and it allows other caregivers. So thinking about other, the medications and the equipment, but also the comfort stuff. Things that if, a caregiver can't get to school, what is a favorite book or something that's going to be in there for that child? Photos of family members, those evacuation plans. We've been doing a little bit of work here on this and helping families, thinking about, families might have bars on their windows. So how do you think about evacuation plans, meeting places, stairs for families that have children that, have medical complexity, and how, if they're non-ambulatory, how are you going to get them out of the house? Power wheelchairs, having that shelter in place plan. There's lots of great resources on that that you can access for children. And again, this idea of training and supporting caregivers, common theme, something that we need to be thinking about across all sections, and also recognizing how much a family can take in a visit. Recognizing, like, I just think, like any of us, maybe you just pick one thing to go over, and recognizing that families are not just, I always think about those care maps. They're not just worrying about one thing with us in our office. And so maybe thinking about how that training is driven by the family's goals and their needs. And I also think about, it's important in this space to remember the role of community health workers, our community partners. There's plenty of, I know in our area in Philadelphia, and I'm sure in many other cities and areas, not everything is going to come from our medical space. So there's often community partners that can help support some of these efforts. I know for us, and like the Red Cross has been an amazing partner for us for things like some of the smoke alarms that I alluded to earlier. So connecting those emergency responders. The one thing I've learned in our state of Pennsylvania is that every county has sort of a different approach to notifying. Some have registries of kids with special needs, some don't. So it's not just what's happening in your state. Sometimes it's very local. And so connecting with those local responders and helping partner with them, especially around issues like utilities, are important. Next slide. I think here we have some resources that I think AAP did a really wonderful job, and want to really thank them for partnering on this, with some of these great links for you to access some of the things that I spoke about. And there's my contact information.